Hey guys, Miss Bowles here. Let's get this party started again. We don't know when little Leah may come. Anyway, here we are today talking about inflammation still, and now we are on nephritis, and our learning objectives are the same as normal. Pathophysiology, etiology, risk factors and prevention, clinical manifestation, all those things we'll talk about today. Let's start off with just a little funny about nephritis. So it is funny, but it is all about the tubules, so we'll talk about those. Here's a little bit of a picture here. The overview is that nephritis, that itis, usually means infection or inflammation, and nephro is kidney, so we're talking about inflammation of the kidneys. And the classification is based on the area of involvement. So glomerular nephritis is the glomerular capillary membrane. So here we have a normal kidney, and here we have nephritis, because this is the inflamed kidney, right? And then one important type of glomerular nephritis that we'll talk about is APIGN, apping, and that is acute post-infectious glomerular nephritis. This develops as a response to strep, so it can be group A beta hemolytic streptococcal infection of the skin, like impetigo, or it can be of the pharynx, which is strep throat. So that's really important, because one of our questions that we may want to talk to our patients about when they have signs and symptoms of nephritis is, have you had a strep infection lately? Have you had strep throat? Have you had impetigo? Okay, so in the acute post-infectious glomerular nephritis, you have glomerular damage that happens from the immune response. The membranes thicken, and then you have obstruction of capillaries, and so you have a decreased GFR, and you'll have, as that allows vascular permeability, so it allows things to move through, we're going to excrete protein, red blood cells, and red cell cast, so we're going to be able to see that in the urine. And we'll also have retention of sodium in water, so we're going to see edema. So we'll talk about the signs and symptoms in a minute. But in chronic glomerular nephritis, here's a nice little picture. This shows what a normal kidney looks like. I'm all about pictures. And then this shows what the glomerular nephritis looks like. This is the inflammation over here. And then if you look, kind of zoom in here, this shows you that it's the glomerulars that is the problem. So chronic glomerular nephritis is often the end stage of other glomerular disorders, and you see a rapidly progressive glomerular nephritis. You can see lupus nephritis or diabetic neuropathy. So all of those can be causes or types of nephritis. And then there's also the famous idiopathic nephritis, which means we have, no idea why, right? Usually it's a slow progressive destruction of the glomeruli, and you see a decline in renal function, and the kidneys decrease in size, and the surfaces become rough, and then the symptoms start to develop, and sometimes we don't notice wouldn't even notice a decrease in the size of the kidney until we start to see some symptoms. So there's different kinds. One kind is the lupus nephritis, and that is a severe consequence of lupus disease or systemic lupus. About 60% of people develop that, and it is a big cause of morbidity and mortality among people who have lupus. The trigger is usually, excuse me, there's students going by in the background, immune complexes in the capillary wall. And you can see anything from just a little tiny bit of hematuria to massive proteinuria. So those things will show up in the urine. And it can be slow or it can be fulminant. Fulminant means sudden onset and rapid development. Goodpasture syndrome is another type of nephritis that can happen. Goodpasture syndrome, that's really a rare autoimmune disorder. We're not really sure what causes it, but it's these formation of antibodies to the glomerular basement membrane, and there's this rapid progression to renal failure. And patients are usually either 20 to 30 years old, or they're over 60 years old. But the thing about this is it's not just limited to the kidneys, but it might bind to the alveolar membrane, so you'll see pulmonary hemorrhage. That's why it can be bad. It affects more men than women, and it's most prevalent among Caucasians. So the etiology of nephritis depends on where it happens, so it's distinct for each type. So with lupus, it's autoimmune problem. With glomerular nephritis, it could be infection. That's the acute one. We talked about the acute post-infection one. It can happen from diabetes, lupus, and then the tubulointerstitial nephritis can happen from an injury to the tubules. So some risk factors would be diabetes, obviously, or GU infection, babies who are premature, trauma, his family history, other diseases that can damage the kidneys, drug abuse, chronic use of over-the-counter painkillers. How do we prevent it? Well, hard to prevent something if we don't know what the cause is, but we try to prevent the viral infections through good hygiene, and then diabetes and blood pressure control, and no smoking, because smoking and drinking will kill you, and then maintain a healthy body weight, right? So here is a nice little picture of glomerular nephritis, and I have a handout for you to color, to add to your coloring pages. This has a really good explanation. Talks about the antigen-antibody response from a recent infection, right? That's one way. And that causes inflammation, which decreases the GFR. And then some of the symptoms can be headache, blood pressure. Edema is a really big sign of glomerular nephritis. We see that a lot, especially periorbital edema, which is around the eyes, and I think I have a good picture of that for you next. Malaise, low-grade fever, weight gain, and then what we see in the urine, hematuria, proteinuria, oliguria, all those things. So here's a picture of periorbital edema. You can see that edema above and below the eyes. With acute glomerular nephritis, it can be asymptomatic, or you can have an abrupt onset of this flank pain or mid-abdominal pain, irritability, malaise, fever. Hematuria, microscopic hematuria, is present in almost every case, and gross hematuria can be in up to 50% of cases. So the edema, like I said, it can be dependent edema, so it can be all over, or it can be in the eye area. And acute hypertension that can lead to encephalopathy can also be present, or oliguria may or may not be present. So oliguria, y'all know that means scant amount of urine, a small amount of urine, right? So in acute post-infection glomerular nephritis, what we see is an abrupt onset of the hematuria. We can have proteinuria, salt and water retention, azotemia, and all of those things can also be seen really in any of the types of nephritis. The azotemia, that just means an increased BUN and creatinine rate. So those are the waste products, the abnormally high levels of nitrogen waste products in the blood. And what you'll see is this abrupt onset of these symptoms about 10 to 14 days after a patient has strep throat or one of the other types of strep infections. They might have brown or cola-colored urine. They'll have salt and water retention, which is going to lead to their blood pressure being up. It's going to also lead to edema. They may have periorbital edema, right? And then fatigue, anorexia, nausea, vomiting, headache, malaise, all of those different symptoms. So what do we do? Well, we're probably going to have a nephrologist, a primary care provider, nurses, pharmacists, dietitians, nutritionists, all different types of people trying to get rid of all of these symptoms. The tests that we're going to use are throat or skin cultures. These are going to be things that we're going to use to determine if they had some kind of strep infection, right? Because that would be that specific type of acute post-infection glomerular nephritis. We might do an anti-strep titer to detect if there are strep exoenzymes. We might also do kidney, ureter, bladder, abdominal x-ray. That's a KUB. We used to do that all the time, but we still do that sometimes in this case. Might check a SED rate, a kidney scan, might do a biopsy. That would be the most reliable diagnostic procedure because that would tell us which type of glomerular nephritis or nephritis that we have, what the prognosis is going to be, what the treatment is. But those renal biopsies are done percutaneously, so they kind of go in with a needle that'll take a little sample out, is really what happens. Some other tests that we might do a BUN, and just in case you don't know, I kind of already said this already about the nitrogen waste, but the BUN measures urea nitrogen, which is the end product of protein metabolism, and that's caused by the breakdown and metabolism of dietary and body proteins. Urea is eliminated from the body after it's filtrated through the glomerulus, so you might see small amounts absorbed in the renal tubules, and glomerular diseases interfere with the filtration of these byproducts, urea and nitrogen, and that causes the blood levels to rise. So you'll hear a lot, see a lot, read a lot about all of these different things. Also the creatinine, that's another metabolic byproduct caused by skeletal muscles and excreted by the kidneys, and that makes it a good indication of whether or not the kidneys are functioning well. So if you have an increased creatinine, that's not a good sign. Normal values are lower in older adults because of decreased muscle mass, but levels that are greater than 4 indicate a serious renal impairment. So that would be important to know, I would think. Disorders like nephritis affect glomerular filtration and decrease the creatinine clearance. Another thing that we might do is electrolytes, and obviously we're going to do that. Their impaired kidney function means that their function is impaired, and so it's going to alter their excretion. We're going to have to monitor those to prevent complications. Our urinalysis is probably going to show RBCs, right, because of that blood and protein in the urine. And a 24-hour urine specimen might be the best way to determine the amount of protein in the urine. So let's talk about medications that are used to treat this, usually to treat the underlying disorders, right? So reducing inflammation, managing symptoms, sodium restriction and diuretic might treat edema and mild hypertension. Antibiotics, obviously if we have some kind of strep infection going on, it would be important to make sure that we have the antibiotics to address that. So we have to make sure that we do avoid the nephrotoxic antibiotics, though, like aminoglycosides and cephalosporins. So that's important. And if we have Goodpasture syndrome, or if we think this is related to lupus, we may need to do aggressive immunosuppressive therapy. So that would reduce the risk of end-stage, I don't know why it says state, but it should be end-stage renal disease and renal failure if we start those early. Prednisone is a steroid. We might do that in large doses and taper it, and then we might also do cytotoxin, Imurin, and Celsep. Those are all immunosuppressive, but we would avoid those in the acute post-infection glomerular nephritis. We can have a problem with, looks like if we have, obviously the kidneys are not functioning well, and so we may have hypertension, and if we have severe hypertension, which we'll talk about when we get to perfusion a lot, but if we have severe hypertension, then we might have cerebral dysfunction, and then we're going to use hydralazine or dioxide to kind of get some of that fluid off and get rid of that hypertension. Okay, so more pharmacological therapy, ACE inhibitors or angiotensin receptor blockers, ARBs. So ACE inhibitors are ARBs to replace protein loss with nephrotic syndrome and to hopefully try to slow the progression of renal failure, and antihypertensive to maintain blood pressure within normal levels. Sorry, I can't speak today. And if they have systemic renal hypertension, that's associated with a poorer prognosis. Okay, so moving right along. Another thing that we're going to do is we want to make sure that they rest during the acute phase. Fluid requirements are determined by checking their urinary output, weight, blood pressure, serum electrolytes. They might have a sodium-restricted diet and protein-restricted. Complete proteins like milk, eggs, cheese, meats, fish, poultry, and soy are usually allowed, but they might limit the other proteins. And plasmapheresis may also be done with immunosuppressive therapy. Plasmapheresis is plasma exchange therapy, which removes the damaging antibodies from the plasma, usually if you have the rapidly progressing glomerulonephritis, and also in Goodpasture syndrome. RBCs are returned to the patient with albumin or human plasma to replace the plasma that's removed, and it's usually done in a series of treatments, so not all at one time. And complications include, just regular IV catheter complications, as well as fluid volume shifts. You're taking stuff off, putting stuff in, and maybe some altered coagulation. And next we get to some slides that I'm excited about, because I've decided to just put some interesting and fun family pictures in there. So lifespan considerations, we'll talk about children first. If you suspect acute focal bacterial nephritis, renal abscesses, or pyonephrosis in children. And that pyonephrosis, the Greek word pion, means pus, and then nephro, of course, means kidney. So that's an infection of the kidneys in the collection system. And the pus kind of collects in the renal pelvis and causes distension of the kidney, and can also cause kidney failure. So it's important to get good pictures and monitor that well. So, pregnant women. And yes, that is my sweet, I go back to this. This is my sweet Ella. That's my granddaughter that's 9, just turned 9 last week. And this picture, that's little Liam right in the middle of the heart. And that's my sweet daughter-in-law, Krista. And that's my son, Luke's hand. But in pregnant women, especially with lupus nephritis, pregnancy may increase the risk of a flare-up, and also more risk to the pregnancy with preeclampsia, perhaps fetal loss, and preterm delivery. So we have to keep a good eye on pregnant people who have it. And we're going to really just make sure the whole team is looking out for the baby and the mama. Older adults. And this is a picture of my mom and my stepfather, Richie. But in older adults, we see prevalence of acute interstitial nephritis, and that happens a lot of times because of the PPIs that they're on and antibiotics. They also have an increased risk of end-stage renal disease, so that's important to watch out for. They also have the highest mortality risk if they happen to develop the disease while they're in the hospital, and they may have fewer symptoms. It may be nausea, malaise, arthralgias, and proteinuria. They may also have pulmonary infiltrates because of a pre-existing condition, right? Okay. So the nursing process, we're going to provide a lot of education and support. Of course, this might interfere with their normal roles, so it's important to kind of talk to them about self-image and loss of identity and things like that we would normally talk about with them. What are we going to assess? Sort of all the things that we've already talked about, but especially for facial or peripheral edema or weight gain, fatigue, nausea and vomiting, headache and malaise. Check to see what their history is as far as diabetes, lupus, kidney disease, and of course ask if they've had a recent strep infection, medications as well, and check out their physical appearance for that edema, vital signs, weight. So the nursing diagnosis that we normally see, right, nothing unusual there. We want to maintain a urine output right here, 0.5 milliliters per kilogram per hour. We want dietary intake that meets the needs but doesn't overload their kidneys, right? No signs or symptoms of infection and no alterations in skin integrity. And we also have some additional goals for pediatric patients, and yes, it's my granddaughter again, Ella. We want them to stay on track with education, so we don't want to have a whole lot of time missed from school, and we want them to be able to participate in diversional activities during bed rest and activity restriction. So obviously this is activity. I should have had a picture of her playing video games or something, but I love it when she's outside and playing. Bed rest during the acute phase, like we talked about, fluid status monitoring, preventing infection and skin breakdown, and trying to maintain those nutritional needs without overloading them and providing support. We want to prevent infection, obviously, And so that's a nice little picture of an infection. Minimize invasive procedures, good hand hygiene, limit visitors, and monitor vital signs. Skin integrity, we're going to turn the patient, all that, pad the body prominences, keep the bed free of crumbs and wrinkles, right? And here we go with fluids. We may have to restrict the fluids, and we may want to do vital signs regularly. So we're going to monitor those vital signs, I&O, fluid and electrolyte status, ascites, so any kind of fluid buildup in the stomach, and measure the abdominal girth, specific gravity of the urine. We might do ice chips in limited amounts. Oops, sorry, lost it. Frequent mouth care, and monitor and regulate the IV infusions. Okay. They need to rest, so we want to prevent any unnecessary fatigue, schedule activities to provide for rest, help them with ADLs if needed, reduce the energy demands, and limit visitors, and just talk about the process of the disease process when there is fatigue. And healthy self-esteem. And we want to look for them to have normal urine output, no areas of redness or any kind of skin breakdown, temperature within normal limits, and keep them from any secondary infection. We want to keep their weight at the pre-illness level and keep them tolerating daily intake. Take their medications as prescribed and make sure their electrolytes are good, sodium and potassium levels are good. And if their progress is not satisfactory, we need to do a thorough nursing assessment, pain level, diet, tolerance, and vital signs, and may need to do some further diagnostics, CBC blood cultures, etc. All right, guys, keep it up. We are almost done. So that ends our lecture on nephritis. Hope that helps answer any questions. You can always email me if you have further questions.